Hello, my name is Rob MacDougall. I'm in the Social Sciences Department. I teach philosophy. And I'm going to talk to you today about health outcomes. And we're going to talk a little bit about justice as well. And I thought I would begin by telling you a little bit about the difference between philosophy and psychology and what kind of things it is that philosophers do, what kinds of questions we're equipped to answer, and what kinds we're not. So in order to do this, I want to show you three slides that all illustrate something about health inequalities. All right, this first slide is a slide that shows graphs from a study called the Whitehall study. This was a very famous study done in the early 80s in the UK. Now, in the UK, they have a single-payer healthcare system. So in the UK, everybody gets the same health care, theoretically anyway, everybody gets the same health care. And one of the reasons the Whitehall study was such a good study is that the Whitehall study followed 4 different groups of people that all worked for the government. They were all clerics in the government. So they all lived in the same area, they all lived in Greater London, they all worked for the same company, so they had stable employment, and they all had the same health care because they all got their health care through the National Health Service. One of the things that the Whitehall study showed, so if you look at the graph, you can see that there's 4 different categories that they're tracking, and they're looking at mortality for each of these categories. Black is administrative. That's the highest, those would be the people that are the highest up in the organization, in the government. They have the best paying jobs. They typically have the most education. And they also have the most authority within the workplace. Next is the professional executives. They're just a step below the administrators. Then you have clerical, and then you have other. Other would be other people that work for the government but are generally the lowest paid group. They have the least education, and so on. What the study found was that there was health disparities, health inequalities between these 4 groups. And it seemed to be the case whenever they did the study. So the first section is between 0 and 9 years of follow-up. The second group there is 10 to 19 years of follow-up. And then the third group is 20 plus years. And what they discovered is that the mortality was proportional to how low down in the organization you were. So you can see that the other has the highest total mortality at every single point when they followed up. They had the highest mortality, even though they lived in the same place and they had the same health care as everybody else. Second highest was the clerical. Third highest was the professional executive, and then in every case, except for one little blip in the middle there, the administrators had the lowest mortality. So the people that had the highest paid jobs, the most institutional authority, generally had the best health outcomes, and it was a fairly robust result. All right, so let's look at a second study here. Okay, now this is a study that shows infant mortality by race. All right, so you can see from the graph here, it's looking at 3 different years: 2000, 2005, and 2010. And it measures infant mortality by deaths per 1,000 live births. And the first group there is the total mortality. The second group is white, non-Hispanic mortality. The third group is black, non-Hispanic mortality. And the fourth is Hispanic mortality. All right. So again, you can see pretty big inequality, this time as a function of race and not as a function of social class or job responsibility or income. All right. Black, non-Hispanic has way higher infant mortality rates than the other 3 groups. So it's a different kind of inequality. All right. Third, now this graph shows life expectancy at birth for males and females. Now this is actually data from the UK, but it's very similar in the US. In both the UK and the US, there's an inequality based on sex. Women tend to live, on average, about 4 years longer than men. And that's been true whether you were born in the 80s all the way up to the present time. Your life expectancy is about 4 years longer if you're a female than it is if you're a male. All right. So when I look at these data, when I look at this data, there's some things that as a philosopher we're interested in, and it will be a slightly different set of things that either psychologists or sociologists are interested in. Probably the chief difference between psychology and philosophy is that psychologists tend to look at empirical data. They're looking at scientific studies, things that can be learned primarily by doing scientific research. Philosophers use that data, which is part of the reason why philosophy and psychology get along so well, is because we need data to talk about things. But we're more interested in the concepts that are at play here. We're interested in questions like, if there's an inequality, does that necessarily mean there's an injustice? What do we mean by injustice? How do we know for sure if there is an injustice? What kinds of things should we do in order to, or what kinds of things would it be permissible for us to do in order to eliminate an injustice? So we're interested in conceptual kinds of questions. In other words, philosophers are generally interested in questions that you couldn't solve just by doing some kind of empirical study, if that makes it easy to remember. So, the question that I want to ask today is, are any of these, are all of these inequalities unjust? And if they are unjust, what makes them unjust? How do we know that they're unjust? Part of the reason that we ask that question is because we want to know, should we change things? Should we change the way our healthcare system is set up? How could we change things in order to improve it? Now, I'm not going to get too much into that, and part of the reason that I can't get too much into that is because, like I said, philosophers have limited insight into how to achieve the kinds of goals that we might think we're morally required to have. So we might figure out that the system is unjust and that some kind of inequality needs to be changed, but then we would likely have to pass off the question to some extent to somebody in another field who could then figure out, well, how is it that we can go about eradicating this inequality? That's a really simple way of understanding it, but it's true for the most part. All right, so I want you to do something right now. So take out a piece of paper and a pencil, and I want you to write down which, if any of these three examples that we've discussed so far, seem like it involves an injustice to you. All right, so are any of these inequalities injustices? So the first slide, remember we had people's health outcomes, their mortality, seem to be on a spectrum according to how well paid they were. So the higher paid you are, the better health outcomes you tend to have. The lower paid you are, the worse health outcomes you tend to have. All right, so does that seem unjust to you? And the second one, we said infant mortality seems to vary a lot depending on race. So for white people and Hispanics, they have relatively low infant mortality. Black, non-Hispanic babies suffer from really high infant mortality. Does that seem unjust to you? And then third is the difference between men and women, right? About a 4-year difference in life expectancy. Does that seem unjust to you that in most industrialized countries, women tend to live about 4 years longer than men? All right. All right, so let's go on and I'm going to talk about justice a little bit now. All right, so most of you probably have some idea of what it is that you mean when you say that something is unjust, or that you think one of these health outcomes is unjust. You have some idea of what that means. A lot of times people use the term unjust only in order to mean something like, we really don't like it. So it expresses a really strong negative emotion, like, it's unjust that minimum wage is so low, or it's unjust that people get treated in this way or that way. And they don't mean necessarily that they thought through what justice is and what a just society would look like. What they're saying is that they have a very strong negative emotion about the way things are. So what we're going to try to do is we're going to try to give a little bit of a definition to justice and then see what follows from that definition of justice. The formal definition of justice, as philosophers have talked about for a long time, says just this. It says the formal definition of justice is treat equals equally. Treat equals equally. So if two people are the same in the relevant respect, then you have to treat them the same way. All right? So to give you an example of this, let's say you're taking a test for Professor Allman's class, and you get 85% of the questions correct. And the person next to you also gets 85% of the questions correct. Right? Well, Professor Allman would have to give you both the same grade, because I presume in Professor Allman's class, like in most other classes, you get graded according to the number of answers that you get correct on the test. All right? So you could say that Professor Allman has to treat equals equally, right? She has to give the same grade to people that get the same number of questions right, and she has to treat unequals unequally. If one person gets a 75 and the other person gets a 95, she can't give them both the same grade. She can't give them both A's. She has to give the one an A and then the other a C. All right? So treating equals equally also means treating unequals unequally. But think about if we did things slightly differently, all right? And this is what makes treat equals equally just a formal definition of justice and doesn't necessarily tell us a whole lot. Let's say that the important characteristic that Professor Allman had to grade according to was not how many questions you got right, not the percentage of questions you got right, but was instead the amount of effort that you put into studying for the test. All right? So imagine that she asked all the students to log the total number of hours they spent studying for the test, and then she asked them to rate themselves on how much effort they put into it, like were they checking Facebook the whole time, or were they really focused on learning everything? All right, and then she assigned grades not on the basis of the percentage of questions that you got right, but on the basis of how much effort you put into it. Well, that would also be, in a way, that would also be a just solution, right? If we're just going from the formal definition of equality, which is to treat equals equally, we've chosen a different characteristic to look at when we're counting who's an equal, but we're still treating equals equally. So if two students both put in 20 hours at 80% effort, she'd have to give them both the same grade, right? Whereas if another student spent only 1 hour and put only 1% effort, that person would get less of a grade. So she would still be treating equals equally if she did it that way. So that's why we have to specify the formal principle of justice. We can't just leave it at treating equals equally, but we have to say treating equals in what respect equally. And for grades, everybody agrees, or most people agree, that treating equals equally means treating people that get the same number of questions right on the test equally. It doesn't mean treating people equally that put in the same amount of work. All right? So would there be a different grade distribution if we graded on the basis of effort? Absolutely. Totally there would be a different grade distribution. But we don't use that. We'll call it that specification of the principle of justice. We use instead the one that says we're going to grade according to the percentage of questions you get correct. All right, so we have a lot of agreement in school for the most part. So you might say that the first specification that we were just talking about would be, we could say it like this: to each student according to their test performance. All right, that's the actual principle that we're working on. All right, so if two students show an equal test performance, she gives an equal grade to them. If two students have a different test performance, she gives them slightly different grades. The second specification of the principle of justice, to each student according to their effort. All right, so that's a different way of dividing up grades. Both are operating on the formal principle of justice to treat equals equally, but they're specified in different ways, and that would yield a different set of outcomes. All right, so I gave you that whole example just to tell you that the same thing is true when we're talking about health. People have different ideas of what is the relevant specification of the principle of justice when it comes to health. So we're going to talk about two major ones. And these are them. The first one is to each person, whatever health is acquired without using force or fraud. The second one is to each person an equal share of health. All right. So let's talk about these a little bit. Just to recap, we said that there's a formal principle of justice, which is treating equals equally, and then we said that there's two material principles or specifications of the formal principle of justice, and those were to each student according to their test performance and to each student according to their effort. All right. Now we're talking about two views of justice and health. The first one is to each person whatever health is acquired without using force or fraud, and the second one is to each person an equal share of health. So what do I mean by the first one? To each person whatever health is acquired without using force or fraud. This just means that people have a right to whatever health it is that they would be able to enjoy by buying, selling, trading, receiving as a gift. Any of those things would count in terms of getting their health or their health care. Those would all be allowed. What wouldn't be allowed, or what would be unjust, would be if somebody forced you to give up something that you would otherwise be able to use for your own health. So if somebody was to take away your medicine, for example, at gunpoint, or if somebody was to lie to you and tell you that this medicine was going to cure you, but in fact it didn't, those would be basic instances of injustice. All right, so I want you to imagine then two different guys. Both of them have allergies. They're both born with allergies, all right? The first guy works hard. He uses some of his money in order to buy allergy medicine. He's able to reduce his symptoms. All right, now he's acquired some extra health, more health than he had before, by paying for it. The other guy takes the money that he could have used on his allergy medicine, and he pays for new Bluetooth headphones. All right. Now there's a health inequality, right? Because the guy that bought that allergy medicine, he's a little healthier, we might say, than the guy that didn't. But this view says that's not really an injustice. It is an inequality, but the other guy could have made a different choice, and he could have bought the allergy medicine, and then he would have been healthier. All right. Now imagine a slight twist on this story. Imagine that the first guy was born into a very wealthy family, all right, and he took some of his money and he bought both allergy medicine and Bluetooth headphones. And the second guy was born into a very poor family. He couldn't afford any allergy medicine at all. All right, so the guy from family A now has better health than the guy from family B. According to this view, there's still no injustice, right? Because the only thing that counts as an injustice on this view is if somebody is to take your health or the things that you would use for health by either force or fraud, and that hasn't happened. One person was more fortunate than the other, for sure, but there's no injustice there because they just were in a different situation to begin with. All right. The same thing would be true if one person was born healthy and the other person was born sick. Right. On this view, that's not unjust. It's unfair, right? But the people are equal according to this view, in the sense that they have a right to pursue health however they want to, and no one's allowed to stop them. But that's the only way in which they're equal. They're not necessarily equal in terms of the money that they start with, or the health condition that they start with, or anything else like that. All right. All right, so our second specification, or our second material principle of health justice here, is to each person an equal share of health. All right, so some people reject this first view. These two views are mutually incompatible. They're mutually exclusive. They can't both be the case. All right, so you have to choose one or the other when it comes to healthcare. There may be other principles too that would be better than either of these two, but the point is that only one of them can really fit for healthcare. So the second view says to each person an equal share of health. All right, so the idea here is that everybody, because we're not, generally speaking, we don't choose our initial health condition, we don't choose to have unfortunate things happen to us, we don't choose to become sick. It's basically unjust if one person is sicker than another person, or if one person's healthier than another person. And if that's the case, and it's unjust, then people that hold this second specification of the principle of health justice think that society has a responsibility to eliminate this inequality, all right? Because it's an unjust inequality. In other words, so I want you to imagine two women. One woman is born with the BRCA1 gene, which is a gene that predisposes someone to breast cancer. The other woman is not born with that gene. They get older, and the woman with the BRCA1 gene develops breast cancer. And people that hold this view will say something like, well, society has a responsibility to chip in for her health care or to pay for her health care because it's unjust that she should have a worse life than this other woman who wasn't born with that same gene. To go back, of course, the first specification of the principle would say there's no injustice here. They say to each person whatever health is acquired without using force or fraud. So they would say, well, it's unfortunate that she was born with that gene, but there's no injustice there. The people that hold the second formulation say there is an injustice. Here's a potential problem with this second view. All right, now I want you to imagine two different people again. And both have very similar genetics. They both have a very similar biological state of sort of background healthiness. All right. One person chooses to spend his time smoking cigarettes and he drinks a big gulp. Every time that he smokes a cigarette, he drinks a big gulp of Coke. So he does this like 8 times a day. So he's a smoker and he is addicted to sugary drinks. The other guy spends his time exercising and eating healthy. All right. Now, both of these people originally might say have an equal share, have a right to an equal share of health, right? People on this view will say that. But then people diverge when it comes to saying, well, what about in this particular case? It doesn't seem unjust to us if the guy that chooses to smoke and drink big gulps, if he ends up being less healthy than the other guy, because this is clearly one of his choices, right? If they both started with the same deck of cards, one guy has made choices that influenced what he ended up with. The other guy has, well, they both made choices that influenced what they end up with. It's just that one guy's made better choices than the other one. All right, so so people split. They say each person an equal share of health. One group wants to say unless inequalities result from a person's own choices. All right, so everybody gets to start at the same place, but if you make bad choices, you don't exercise, you eat poorly, you smoke, you do other things like that, then that's on you. You're responsible for that. Society has a responsibility to help you up to a point, but they're not going to get you out of that kind of mess. That's not their fault, that's your fault. The second group says, well, now wait a minute. Let's say that let's say that they both made these decisions. One guy's eating well, he's exercising regularly. The other one is eating poorly, smoking a lot, all right? But how would it influence your perception of this situation if you found out that the first guy, the one that was Mr. Healthy, was from a very healthy family, and he was brought up, his parents telling him, always eat healthy, don't smoke. He didn't know anybody that drank big gulps. He didn't know anybody that smoked growing up, all right? The other guy was brought up in a poor family, and they stressed, a lot of his relatives smoked and drank big gulps all the time. They thought this was a valid lifestyle choice. Would you really be willing to say that it was entirely the individual's choices that led them to the point where they had such different patterns in life, So they say, you know, even our choices, even things that look like our choices, like our decisions to smoke, our decisions about what to eat, about how much to exercise, our decisions about the kinds of career we pursue, the amount of education we get, all of those choices are to some extent predetermined. We don't have control over those, and so we can't be held responsible even if we make what seems like disastrous choices for our health. We shouldn't hold people responsible for those because a lot of that's just coming from the way that they were brought up. All right, so the second variation, 2b we're looking at now, even if, to each person an equal share of health, even if inequalities result from a person's own choices. I want to apply these to our original graphs, the ones that we looked at, and ask, what do these different views make of these findings from the medical literature? All right, so we've got two major views, and our second view has two different variants. What do we make of, for example, the Whitehall study? One of the interesting things about the Whitehall study, and about these kinds of data in general is that they don't really give us, it's hard to tell exactly what it is that's causing the inequality in this particular case, for example. So I can tell you a few more details about this study, and it still probably won't completely explain why things are like they are. So what researchers have found is they found that it doesn't matter, there are several things that are correlated with good health outcomes or lower mortality, and it doesn't. They're all robustly related to lower mortality. So this one does it by occupational role, institutional, the place in the institutional hierarchy, right? So the administrators were the very highest group. They're the little black bar, and then it goes down in 4 tiers. And they showed that the health outcomes are directly proportional to how much authority someone has within their institution. So we could call this occupation, right? The same results would hold if we did it according to income. So if you mapped health outcomes as a function of income, you'd see that people with lower incomes tend to have worse health outcomes. People with higher incomes tend to have better health outcomes. The same is true with social class. So if you, now social class is a little bit different from income because, for example, there are graduate students that are basically middle class people that are going to have middle class careers, but right now they're not making very much money. All right, so if you divided it up by class, and you could have lower, middle, and upper class people would tend to have better health outcomes than middle and lower. I think that the most robust correlation is actually between education level and health outcome. So in that case, people with less education tend to have poor health outcomes. People with more education tend to have higher better health outcomes. So congratulations, you guys are in college. You're going to be a little healthier than you would have been otherwise. All right, so we know that all these things are correlated, but I'm sure you have talked in your class about the fact that correlation does not mean causation. So we need some kind of proposal for why it is that these results hold. And the problem is that we haven't really found something that just nails it. We don't know for sure. There have been a lot of things that have been suggested about what's playing a causative role here. But it's very difficult to sort through all that data. And probably, the truth of the matter is it's probably a multifactorial explanation. So there's more than one thing that's determining why somebody's health outcomes are related to their income, their class, and their education. All right. One very important thing to note also about this study, I want to just point this out because it's a point at which I disagree with the authors of your book somewhat. The education, class, and income and job role are all strongly correlated to health outcomes, but the same cannot be said about access to health care. So these things are more determinative of your health outcomes than the amount and the kind of access that you have to health care. So it's not necessarily true that just passing the Affordable Care Act, for example, is going to get rid of this. In fact, we know that that's not true because this study was done in a system where everyone had supposedly equal access to health care. All right, so this is not, these inequalities are not just a feature of having better or worse health insurance or being able to go to better or worse doctors. There's other things that are more important to your total health outcomes. All right, so I said we're going to talk about justice. Is it unjust that there's these different levels of health according to income? Well, the first group, the first view says as long as there's no force or fraud, then it's probably not unjust. All right, there could be a variety of different explanations for why we have these this gradient in terms of health outcomes. But it's hard to think of how this could be due to force or fraud. Now, somebody could come up with an explanation. They could find out, for example, that doctors don't tell poor patients as much about their health status, they don't give them as much information, or that poor patients are not as able to comprehend the things that doctors are telling them. Somebody could come up with an explanation like that. For example, When we look at the one on infant mortality, you can see that it's been hypothesized before that one of the reasons why black babies have higher infant mortality rates is because of the strained relations between black patients and predominantly white doctors. And there's been a lot of psychology research done on the attitudes of patients by race towards doctors and the degree to which they trust them. All right, so have you guys talked about the Tuskegee studies at all? Okay, so you guys know some of the background about perhaps it's been hypothesized that one of the reasons that black patients don't trust doctors is because historically white doctors have done some awful things to black patients, including lying to them about the research and the health care that they're giving them. So let's say that we held the first view of justice. Each person, whatever health is acquired without using force or fraud. All right, and we see something like this graph that shows us that black babies have worse health outcomes. Well, is there an injustice here? Well, it's going to depend in part if it's true that the historical actions of white doctors lying to black patients is in part responsible for this infant mortality rate. If it is responsible for this mortality rate, or partly responsible for this mortality rate, the difference in health outcome itself is not unjust, but it is a symptom of an underlying injustice, which was the historical lies and abuses that were practiced by white physicians on black patients. So they might see some health outcome inequalities and still say there has been an injustice here, but it's because of the past actions of doctors who were using either force or fraud in order to get what they wanted from black patients. It's not the difference, it's not the inequality itself that's unjust. Now the other two groups, remember we had the second view, to each person equal share of health. They're going to look more suspiciously on this kind of data than people from the first view are. But it's not going to necessarily solve the problem for them either. All right, so let's look back at this first graph. This was the Whitehall study again. Right? They would want to know very specifically, now, especially if you're in that 2A where you think that health inequalities are unjust unless they're the result of individual choices. In order to determine that, we'll need to know whether the reason that administrators have much better health than clerical or other workers is because they're making better choices. All right. So those people will want to know things like, well, maybe is it the fact that they just exercise more? Perhaps people that are in the lower paid groups go home and then they would rather spend their time just relaxing, watching TV, whereas people in the upper echelon would like to go home and exercise. They're always interested in accomplishing new things. On the other hand, it could be due to something like this. So it's been hypothesized that part of the reason that you see this gradient within the workplace is because workers on the lower end of things experience a lot more stress associated with their job than people that are higher up in the hierarchy, the institutional hierarchy. And if that's the case, someone might say, well, that's not really their fault. That's not due to a choice that they made. That's some problem with the way that the workplace is. So this inequality is unjust. All right. Now, 2B holds that inequalities are unjust even if they result from a person's own choices. So to them, it won't really matter for any of these three. It won't really matter what the cause is. We won't have to sort out the cause in order to find out whether the inequality is unjust. We just know, because there's an injustice, that it's something that needs to be corrected. For them, they have a little bit of explanation to do when it comes to data like this that shows that women tend to live longer than men. Because they need to explain then, most people would not at a gut level say that this is unjust. They would tend to think that if women live longer, it's probably okay. Well, if that's the case, and you hold the view that health inequalities are always unjust, even if they're due to somebody's own choices, then you would probably need to explain to us why it is that you think that this also, why it is you don't think that this is one of the inequalities that we need to try to eradicate. All right. So just to sum up then, all right, so in each of these views, it's going to matter, each of these views except for the very last one, it's going to matter a lot what the source of the inequality is. And that's, I think, an area where psychologists can help us a lot. They can figure out, and other kinds of scientists too, they can do the background empirical research trying to figure out what the inequalities are due to. And then philosophers say, well, if this theory of justice is correct, then that inequality is unjust. All right? And this is the kind of data then that we could use to potentially reform the healthcare system. And with that, I think I will move on and answer some student questions. Okay. All right, so I'm going to answer a few student questions now. So Ashley asked, do you believe, based on the type of healthcare provider, a patient can be treated differently? If so, how can this problem be addressed? Now, I think what you're asking is, do I think that patients might get different care, for example, if they go to see a doctor at a managed care organization rather than a doctor who's working through a preferred provider organization or a traditional reimbursement, so indemnity insurance is what your chapter called it. I think that patients can be treated differently. So doctors will, there was that opening vignette in the book about the doctor who says, I'm not going to order any more tests because they're probably unnecessary. So managed care organizations, one of the ways that they are able to reduce costs is by cutting down on the numbers of tests that doctors order and trying to be more precise about giving rules exactly when a test is indicated and when it's not. Is there a way to solve this problem? So the worry is that maybe some patients, because they go to a managed care organization, will not get the same kind of level of attention and precautions shown towards them as somebody that goes to see one of the other kinds of physicians that gets reimbursed just for fee for service. No, I think we're going to go more and more in that direction. I think probably in some ways it may be better to go the managed care way, as long as there are good people that are in charge of setting the policies for when the tests are indicated and when they aren't. This is one of the ways that healthcare has responded to sharply increasing prices, and I think that we need more cost-saving mechanisms like that in there, and that they can, on the whole, they can actually promote patient health rather than harming it. It's better if we have clear rules, though, laid down for physicians within the organizations for which they work, rather than just them making gut decisions based on what they think will save the most money in this particular case, if that makes sense. So, for example, for some managed care organizations, it may be that physicians are incentivized by saying, you need to spend less than this total amount on patient health care, or else you'll get personally financially penalized. Well, that's not very good, because that does incentivize physicians to reduce the amount of care appropriately or not, so that they don't go over that total limit that's been set for them by the company. So I think a better way to do it is to have clear guidelines about when a test is indicated and when it's not, that's based on evidence, if that makes sense. Let's see, other questions? When researchers, this is from Isaac D.O. When researchers compare and contrast the pros and cons between the single-payer system practice in the UK to the multi-payer systems practice in USA, it was found that even the wealthiest Americans had poorer health profiles than the average working-class English person. So what factors prevent America from practicing the single-payer system as fellow industrialized countries? Now, this is a good question based on the chapter that you had. However, I don't agree with the way that the chapter set up this problem. So remember the graphs that we looked at the beginning strongly suggested that health outcomes are determined more by things other than the kind of health care that you have access to. So it's a big mistake to equate health with health care. The two are related, but on the very broadest level, people tend to be healthy based on lifestyle choices and their place in society and a whole bunch of other things that don't directly have to do with the kind of health care they have access to. Now, that doesn't mean that having access to healthcare never helps your health outcomes. Obviously it does. We all get sick sometimes, and we can think of people that if they hadn't been able to go to the doctor would have had much, much worse health outcomes. For example, my dad had a heart attack. If he hadn't been able to go see the doctor and then have coronary bypass surgery, he probably wouldn't be alive anymore. So in particular cases, it does make a difference. But on the broadest levels, when you really zoom out and you look at all of society, it ends up the healthcare system isn't the strongest determiner of total health outcomes. Now, the question about whether a single-payer system would be better than the kind of multi-payer system we have in the US, that's a really complicated one, and probably not one that I'm totally equipped to answer for you. Like I said, I'm a philosopher, and we're not primarily interested in those kinds of questions. They're incredibly complicated. The more research you do, you would find out about that. I will say one thing, though, which is that it's not the case that most other industrialized countries have single-payer systems, which I think is, I don't know why your book said that. So, for example, Germany has a multi-payer system. I believe Switzerland does. I believe Japan does. I think a lot of the different industrialized countries have multi-payer systems, which doesn't mean that they're not government run in some way. It just means that it's not a single payer. So two examples of single payer systems would be Canada and the UK both have single payer systems. But I don't know that the relevant question is whether we should go from multi-payer to single payer. I don't know for sure that would necessarily mean better health outcomes at all. I don't think it's true that it would.